Okay, you are live, Anita.
Great. Good morning. My name is Anita Day. My pronouns are she, her, and I am chair of Eastern North Herts Teaching NHS Trust. This morning, it is Wednesday, the 8th of July, 2026, and this is the meeting of our board in public. I'd like to welcome members of the board, any staff members or patients or members of the community who may be joining us via YouTube, either on the live stream or indeed afterwards. We've got a packed agenda, so I'm going to try and keep it as short as we can, and go straight to, first of all, declarations of interest. We have the normal ones on the website, but if I could just ask if any board colleagues have any specific declarations they'd like to raise for today's agenda. I don't see any hands, so thank you very much. Apologies for absence. I've received 3 apologies. Lucy Davis, our Chief Operating Officer, but her deputy Claire Moore is deputising for her. Jill Hooper, one of our non-executive directors, and Ailey Murray, our Director of Communications. I think I would now go on to our staff story, but it looks like our staff member hasn't joined us yet. So let's just have a slight delay and let's go straight through to minutes, if that's all right. So the minutes are in the pack. I wonder if I could ask for any changes, any comments, or are we happy to treat those as a true record of our last meeting? Please raise your hand if you've got any changes you wish to make to those minutes. Okay, I can't see any hands. Thank you very much. We will take those as a true record of that meeting. Moving on then to the action log. Stuart, I'll hand over to you.
Thank you. So there are 2 open actions in orange which aren't due yet, and both are on track. So that relates to terms of reference and UEC performance improvement timeline. Unless there are any questions in regard to those, then the other 2 actions which are being proposed to close relate to May's patient story. It was really great news that the ICB has agreed a consultant-to-consultant referral process showing the difference a patient story can make. And then the other action, conscious that the patient wished to remain anonymous, but the action log does provide an update as requested, and the medical director did meet with the patient separately, and an update was provided to QSC. So that action is proposed to close as well.
Great. Thank you, Stuart. David, you wanted to come in.
Yes, I'm sorry I missed last meeting, but just to note that as I myself have IBD, I did have a meeting with our patient as well.
Great, thank you, David. I knew that you would be sorry to miss that one, so I'm glad that you managed to connect with her separately. Teresa.
Thanks, Chair. And just to say that we also have on the nursing front and the operations front a follow-up meeting with the patient to go through some of the areas that she listed around environment, flow and processes, and that's happening in July this year.
That's brilliant. Thank you very much. And again, really, really good that we were, we've responded in that way. I don't yet see our staff member that has joined, so I think I've got no alternative but to carry on with the agenda. If I could ask somebody please to contact her and just find out what the issues are. In a worst case scenario, perhaps she can move into somebody else's room and do it from there. But I'm not quite sure. It will be really sad if we aren't able to hear from her this morning. But let's hope that we can get that sorted. Let's move on then. Item 6 are public questions, and I believe, Stuart, that we haven't had any public questions this
correct.
time. Thank you very much. Right, let's then move on to the chair's report, which is a verbal from me. And I've got several things that I wanted to share with you all, and also ask for ratification from the board. The first one was the great news that since our last board meeting, we are delighted, and I am delighted, to confirm that Martin Armstrong, who was our Chief Finance Officer and our Deputy Chief Executive Officer, was, after a very rigorous and very close and very difficult process, was appointed as our substantive Chief Executive. Really delighted for that. He knows this organisation well. He may well say a few words when he comes to his Chief Exec report, but it is fabulous news, and we're delighted with that. Also delighted to announce that Teresa Murphy has very kindly agreed to become our Deputy Chief Executive Officer. Again, with two such stalwarts of the organisation, it's a fabulous combo, and I think. Really looking forward to you two working together. I think it's a great, I feel we're in safe hands with you two at the top of the organisation. So that's really good news. A couple of things then for ratification. We've had a couple of things that we need to get that I need to get your approval for. A couple of weeks ago, a contract for the SFBC imaging equipment needed to be approved in the gap between board meetings, and therefore Martin and two non-executive directors went through the process for a chair's action. It was also, I think, went through a Finance, Performance and Planning Committee as well. So it did go through. Can I ask for board's ratification of that chair's action? Thank you. I'm getting some nods. Yeah. Thank you very much. The second thing that happened. Oh, Kevin, did you want to talk about that particular? Okay.
Apologies. I was trying to confirm.
Oh, okay, brilliant. Thank you. The second thing that I need your ratification on was the submission of the quality account, which needed to be submitted by the 30th of June. And again, that was before our board meeting. So again, we did that via chair's action. Again, chair, chief exec and two non-executives. I think most committees saw elements of that quality account as part of their committee work. Can I ask for board confirmation that your ratification of that? Thank you very much. The third thing I wanted to just bring to your attention is something that hasn't happened yet, but is going to be happening in the near future before our next board meeting. But it's in a much wider area. I think many people, certainly our board, but I think many of our staff and also our patients and communities will be aware that in the last few weeks, we've had two really distressing, really difficult reports that have come out, Donna Rockenden's and also Lady Amos, on maternity services, both one specifically to Nottingham University hospitals, one more generally across the country. These have been really distressing for anyone who is involved in the care of expectant parents and their babies, but of course also for parents themselves, who will understandably have been very concerned and anxious by some of the things that they will have read in that report. As a trust, I want to reiterate that we are absolutely supportive of the process that we, NHS England, are going through, that every organisation in the country that is involved in the care of expectant mothers and their babies, to review the findings and to really reflect on the learning from it, to just minimise the chances of anything like these awful things happening, certainly here at Lister. As part of the process that NHS England are doing, there are various reviews and audits that are going to be needed over the coming months. And the two that are specific that need to happen in the next 30 days is one about mortuary standards. The other is about joint accountability structures. And we need to report back on those by the end of July, which clearly will be before the next board. We are already working on those things. We're all started work on the other ones as well, of course. but I would like board approval to delegate the ratification of that response to Quality and Safety Committee. Can I have board's agreement to that? Thank you very much. But I think it goes wider than that. That's kind of the business bit. But I really do want to speak to any expectant parents out there who may be listening to this and may be anxious. I think you will know, and I think you will already have had this advice, that, you know, if you have any concerns ever about your baby or your health, please speak to your midwife or your clinical team and just and talk to them about it. And I would say, you know, that if you're at home, we do have a dedicated phone line that you can call in if you've got any concerns. But the most important thing is, if for any reason you have concerns and you can't get through on the phone, please just come in anyway. Nobody here is ever going to make you feel stupid for worrying about your baby's health or your own health. So please, if you're anxious, seek help and from whoever, seek advice and come in if you need to. I do, however, given that all this sort of sad things, I did also want to talk about, as it happened, something really nice. On the day that the Ockenden report was published, I happened to receive an email from a woman who had just given birth, or had recently given birth to her fourth child with us, and had actually had her previous 4 children with her. It was a lovely email, and I'm going to just read just a couple of little bits out of it. Katie was this lady's name, and she had been under the care of Lister Maternity Unit for both this baby, who was born in April, and her previous babies. Katie said, and these are quotes, that she said that we provided outstanding maternity care, that she always felt listened to, respected, empowered, and exceptionally well cared for. She had confidence and reassurance from the team during her pregnancies and during labour, and then following labour through the breastfeeding journey, where in breastfeeding she felt that we were educating, encouraging and supporting her with praise and encouragement, which gave her the confidence to keep going. She finished with, these remarkable midwives across that whole journey have had a lasting impact on my life and my family. It was lovely to receive that on a day where so many stories were perhaps not so nice. I think it's true of us, and I think it's true of all maternity units, that there are sometimes things do go wrong, horribly wrong, and we absolutely need to try and make sure those things don't happen. But for a large majority of our patients, actually, they have a really good experience, and that was just really nice reassurance of that on that day. I'm going to pause there for any questions or comments. I don't see any hands. If not, I will just pause because I'm aware that Day Thorpe has been able to join us. Sorry, Day, I gather that you had a few problems joining us. Day is a member of our staff, and she wanted to talk a little bit about her experiences. And interesting, she works in maternity as well. So I think there's a theme there. Penny, I don't know if you're introducing Day or are we going straight to Day?
No, I am. And actually, you've just mentioned, thank you, you've just mentioned our phenomenal midwives. And we're about to hear from one of our phenomenal midwives. So you're very, very welcome, Day. Day is a preterm birth specialist midwife, a role that she's been doing for around 4 years now. And it's in that capacity that she's sharing a story with us today. So in the 4 years that she's been doing that role, she's been able to spearhead quality improvement changes to support national drivers, including the perinatal optimisation to improve outcomes for preterm babies. She's also been able to share some of these achievements in regional, national, and international platforms. She's spoken on a big stage and she talks at conferences about the learning. And if that wasn't enough, she's also written a book. So, it's designed to support women and families, incorporating anonymised women's stories in, excuse me, anonymised women's stories into the book for healthcare workers and for women themselves. And the idea is to educate and to teach women how to advocate for themselves in the healthcare setting. And she's going to, in a moment, share one of those stories with us. And it actually led to her being nominated for a Daisy Award. So we're very, very lucky to have Day Day and also to have her on the call today sharing a story. But before she does, I just want to offer a trigger warning to anyone listening. So this is a very powerful story and it's a very impactful story, but it does relate to baby loss, or there are references to baby loss in it. So I would encourage anyone listening now or watching this back, please do consider that before you continue to hear Day Day's story. With that in mind, Day Day, I would love to welcome you to the call to share your amazing experience.
Thank you very much. Good morning, everyone. It's a pleasure to come and to speak to you and share a bit about my journey into preterm birth and a story of one of our wonderful service users who has been able to experience good care from us as well. So I'm just going to share my screen with you. If you give me a moment, hopefully we'll get this right. About 100 tabs going all the time, so hopefully that should be coming up on your screens to see.
We can see it. It's all right, Day
Perfect.
Day.
Thank you. So I just wanted to kind of talk a little bit about my service. Well, it's a collaborative service. So the preterm birth service, I work with some amazing consultant obstetricians. And in that time, we have the service started in 2020. So this is a brief overview of what we've achieved in that time. So the service officially commenced in 2020. I started my role in 2022, supporting the obstetricians and trying to embed more midwifery care into that service. And we had some quality improvement along the way, as there's been mentioned. So something like the Life Start Resuscitaire, which I'll talk about in a little bit more detail. The job initially was a secondment and then was made permanent. So in 2023, I became permanent in the role. I was able to get training to offer cervical length scans alongside my obstetric colleagues. So that has helped to facilitate the care that we offer to women in our multidisciplinary clinics as well. We were able to embed more learning into the annual midwifery training days, and we were able to offer a study day as well to our colleagues in 2024. We had midwives, student midwives, obstetric and neonatal colleagues attend this session, and we had service users come in, some with their babies, to share their stories. And as you'll probably find out about me, I'm a huge lover of stories. I love to share women's stories. I love to use that to educate and empower women. So that was, and the feedback from that was amazing. And that sort of led me to publishing my book in 2025 November, where I was able to kind of compile the stories together and use that as a learning tool for healthcare professionals as well as women. And then this year has been very busy so far in the first half with a conference in Barcelona sharing some of our data and our findings from our services, as well as some research proposals that I've put together looking at how we can improve midwifery education using resources such as the book that I published. And just a couple of weeks ago, I was presenting at Maternity and Midwifery Conference as well. So just a quick look at our service. So we offer a lot of women who come into our service very holistic care. It's not just kind of assessing their preterm risk. It's kind of the entirety of their pregnancy. We look at, what support they need from other specialists as well as ourselves. So we might work with our diabetic specialists, for example, if women have diabetes. We work with our maternal medicine or our fetal medicine if there's complications with the babies. Mental health support. Imagine if someone has had a previous loss, sometimes they are there's a lot of trauma to unpack there, and actually sometimes perinatal support from our mental health midwives or counselling support from a charity known as Petals is something that we will offer to our colleagues, our service users. And we offer continuity of care because we try to see them consistently throughout their pregnancy, myself and my team, and TLC, because actually if you're coming back with a sort of traumatic previous experience, we want to ensure that they enjoy their pregnancy to the best of their experience, to the best of their capacity. And this just shows that over the last 4 years of our service, we've seen an increase in the number of women that are being referred to our service. And most of those women who do come into our service will require cervical length scanning as a means to try and identify if they are at high risk of preterm birth. And up to 40 to 45% of those women will need at least 3 cervical lengths. So on average, we are scanning, upwards of 450 scans per year in our preterm clinic. So we are very, very busy. This is one of the projects that we had initiated, which is a Lifestart Resuscitaire, and this is just a bedside resuscitation that allows for babies to get that life-saving support right after they're born, before the cord is cut. And we're able to do that because charities supported us with the supply of this piece of vital equipment that helps us to, further support the work of prematurity and reduce those morbidities for those babies. And this is just some photos. I love photos. Sorry, I'm going to bombard you all with photos today. Preterm birth study day, where that's one of our lovely consultants on the top left corner. We've got some of our doctors who are practicing their cervical suturing techniques, which is one of the treatments that we offer to women who may be at risk of their cervix opening and having their babies prematurely in pregnancy. So we did a lot of education for the multidisciplinary team in those study days, and we had the privilege of having our parents come in and share their stories and their journeys through that. Some of the other improvement work that we did was trying to facilitate timely optimization. So we set up a preterm birth box in our labour ward so that staff can just grab it if they do have a patient that needs the extra support. They can move quite quickly to ensure that we get the best outcomes for those babies. We've developed a website as well so that patients as well as staff can have access to information, leaflets, and our contact details as well for the service, because we feel that actually that should be available for everyone to encourage women to be a part of their care and access care early. We set up a working group to be able to look back at our data and improve the outcomes, assess what we're doing, how we're doing, share good practice, share learning opportunities as well. So this is the reason why we do it. We do it for these families. We want them to have a wonderful experience of their maternity journey and go home with happy, healthy babies. And sometimes, despite our best efforts, we do encounter challenges, and we are still there to support them through those journeys of prematurity. We put them at the forefront of everything we do, and it's a privilege to be a part of their journeys. And these are some of the lovely babies that I've been blessed to support. And yeah, the impact is we get a lot of praise and feedback. What we want to do is kind of quantify that into actually service evaluation. So that's one of my next projects, is to try and actually see, can we quantify the impact that we're having, rather than all these lovely, lovely, wonderful texts and information that we're getting from patients, which we value and we love, and we keep collections of them. But also we want to know, is this service meeting the needs of our service users? And that's what led me, so again, as I said, to publishing my book on prematurity. I just wanted the stories of women to be heard, and I wanted it to impact other lives and hopefully reduce the risks for women who may not know that they have risk factors for preterm birth, but are just trying to improve that education and understanding and improve empathy and trust building from the healthcare professional's perspective. And as has been mentioned as well, we've taken this both regionally to our East of England groups, where we talk about our findings within our local our unit and the work that we're doing, to London. I've done sort of health inequalities in preterm birth. I've done a talk with some of our colleagues, which was very well received in London last month. I've done the Bradford conference as well, and most fun for me was the Barcelona trip, because obviously it was very sunny and warm towards the end of April. So I did make the very most of that, as well as sharing my presentation. So I did end up in the beach as well. So with that being said, I want to talk about Joy. Joy is one of the patients who I've cared for over the last few years. She did nominate me for the Daisy Award, and I just thought her story was it. There's some stories that you live through that change your life, and Joy was one of them. I have many, but she holds a special place in my heart. So she came to us in her first pregnancy. She was a Black African lady. She was pregnant with twins. She also was found to have fibroids early in pregnancy, and so with twin pregnancies, they come in quite frequently because they need extra scans, and it's just a higher risk pregnancy, which does hold a higher risk of preterm birth as well. So we have that kind of background to work with. She came in with several times with presentations of abdominal pain, which is very, it's not uncommon when you have fibroids as well. Fibroids are growths in the womb that can cause some pain as they develop. They take up space in the womb, they have their own blood supply, and they can become quite irritable to the womb and cause pain. So this was her presentation. She came in 3 times, and on the 3rd time, actually, she was found to be diagnosed with preterm labor. She had a swab test that said, actually, your chance of having your babies early is quite significant. So with that being said, we transferred her to a level 3 neonatal hospital with a neonatal unit that could specialize in looking after babies that would be born that prematurely. And so she gave birth to her twins a few days later at 24 weeks and 6 days, Abel and Felix. But sadly, Felix passed away about a week after birth due to an infection and complications of being so premature. Abel thrived, and he was born weighing 680 grams, spent 115 days in NICU, and between our level 3 Rosie neonatal unit and our Lister neonatal unit as well. So baby went home at 41 weeks and 4 days, weighing 3.3 kilos, and is doing really well now. Joy surprisingly found out that she was pregnant about a year later, and she made direct contact with me. So actually we had formed a bit of a relationship following the birth of her twins when she came back to our Lister neonatal unit. And this is something that I want our service to do more of, is that kind of postnatal support for women, because that is a gap that we've identified where we just don't have enough support for women who've had a preterm birth. She was referred early to our team. I made sure that she got into our clinics early, and she was seen consistently through the early part of her pregnancy and all the way through her pregnancy, actually. So aside from her 10 routine preterm clinic appointments, Joy had 22 triage and day assessment unit attendances, all between 18 weeks and 37 plus 6. 10 of those were for reduced fetal movement, 6 of them were for pain, abdominal pain, 3 were for blood pressure issues, and 3 were for scan reviews. And the reason why I mention this is because when women have experienced a complicated previous pregnancy, their next pregnancy is quite resource intensive, because we have so much to do to make sure that we get it right in the next pregnancy. And then also women are more anxious, as you can imagine. So they present more frequently, which they absolutely should do if there's any concern. That's, as Anita was saying, we want them to come to us. We want them to be heard and feel listened to. And this was her beautiful baby boy. Elliot was born at 38 weeks and 3 days by a planned cesarean section, weighing 3.1 kilos. And they're doing so well. She sent me this picture, I think about a week or 2 ago, of the boys, and they are they sort of look almost the same size now, because they're only a year apart. Irish twins, I think you might call them. But her experience of care in her second pregnancy was much, I think when we sat down and talked to her, she felt so much more held and supported through that pregnancy. And that was primarily because we were able to offer a level of continuity of care. She had some challenges, obviously, getting over the loss of her first one of her twins in her previous pregnancy. She felt that the care that she'd received in the other hospital, there were some gaps in that. And so we started trying to build from the beginning of the pregnancy. It was a lot of building up trust in us as healthcare professionals, that we would hold her, and also building up trust in her own body as well, that she could do this with the right support and measures in place. We could give her the right support, and she could go home with a healthy baby. So I just wanted us to reflect on this case, because the impact of previous loss, as I've mentioned, affects subsequent pregnancies with heightened anxiety. Women will cycle through lots of emotions: guilt, happiness, anxiety, fear, mistrust of healthcare professionals, and mistrust of their own bodies. And our work goes beyond just the clinical care. There is a lot of restorative work that we do, and when we get it right. So frequent attendances, like, there was reports that are coming out that the cost of prematurity, like 3.4 billion, I believe it costs the NHS every year, up to 95,000 £95,000 per baby that's in the neonatal unit from 31 weeks. So like getting it right is so vital, and that is kind of the flag I'm flying. That is kind of what I love to do, is to go and kind of educate. And I just wanted to mention as well, just to wrap out, fibroid pain is real. Like women do come in more frequently fibroid pain, and the women who suffer from fibroid pain tend to be more often from Black and minority ethnic groups, and they're often more dismissed. So there's a lot of work that we're doing in breaking down barriers and health disparities as well. So just some food for thought. So what's next for me and my service, what we're doing? I want to do a full service evaluation. I want to see what our numbers are. It's a very big task, and if anybody knows anyone who is good at analysing data, please send them my way, because this is what my dream is, to identify what we're doing really well, what improvements need to take place, and how effectively we're serving the women in our community. I'm also hoping to get on more platforms tonight. I'm on the Maternity and Midwifery Hour talking about preterm birth and how we can improve outcomes. I've submitted a poster for a presentation at the Baby Lifeline conference in September, and we're also planning to do another service evaluation presentation at the preterm birth conference in January 2027. And just to finish off, I want to say a big thank you to my consultant, Rachel Waldridge, who basically is always championing for both midwives and for women. She fights tooth and nail and quite aggressively to ensure that women have the best care that they need. And we are really, really blessed to have her on our team in maternity. And thank you very much. I shall stop sharing now.
Brilliant, Dede. Thank you so much.
I hope I didn't run over too much.
No, not at all. That's brilliant. I'm going to open it up for questions or comments from anyone, but just while people are gathering their thoughts. No, that's really special, and I think, yeah, and I have to be honest, I visited maternity services many times. I actually wasn't aware that this was a dedicated service, that this existed, and it existed in this format. So really, really special. Lovely. Okay, good hands. So I can stop talking now. Teresa.
I think just to say, Chair, Dede's work permeates across every part of maternity, and it is, it's been a challenging time for us getting all these national reports. But Dede, you are the glue that holds together the service for these women and holds up their voice. And I know you talked about Rachel there and the support that she is for the service, but just to highlight how impressive you are, the glue across our obstetricians, our neonatologists, and also our region, as many of these complex babies and mothers will present to other centres. So I think we need to up your awards, and you need to get a National Midwifery Award. So let's work on that. But without fail, every time I'm in maternity, somebody sings Dede's praises, and it's done in such a humble and dignified way, Chair.
That's wonderful to hear. Thank you, Teresa. Martin.
Yeah, I don't want to add to Dede's blushes on there, but yeah, thank you for leading us through that, because it's a really impressive kind of story. It's an impressive story for the service, and it's an impressive story for your passion and leadership and commitment as well. And I think Joy's story on there just brings it home in terms of the difference that the service really makes. I guess a question I'd have: you've got some really powerful numbers on there in terms of just the increase in the level of activity that's going through the preterm service on there. And we know that we're in that position at the moment societally where, although the birth rate is dropping, the complexity of mums as they present kind of to us and the support they need is definitely going in a different direction. So when you look at the service kind of going forward, how do you think the preterm service is that a short-term issue, or you think this is something that's going to continue to build and we're going to need to look differently at preterm going forward to continue to make it a success?
I think we need more bodies on the ground within this service, because one of the challenges that we face is that I am a one-man band in a single point of failure. So I work 30 hours a week, contracted, but like I go, all the other extra bits that I do is extra. And when I'm on annual leave, if I'm off, like that is time that it's not covered. That is time that women do not have a dedicated midwife to be on the other end, to give them that extra support, to give them that TLC. So this is something that we've been raising this since I came into post, is that it's great, we've got someone now, let's see what the service needs are and let's see where we go from there. However, we do understand the financial constraints of the in current services, but in order to see this service thrive and be more than what it is, which is it's good right now, but there's so much that we can do to kind of improve the care for these women. Our preterm birth rate hasn't come down, although there's been national drivers for the last sort of 10 years. They had tried to shift it from 8% to 6% by 2025. They extended that to 2030 because it had not shifted at all. The complexity, as you've mentioned, is increasing. Women are having babies who weren't having babies 15, 20, 30 years ago. Maternal morbidity is increasing, which means that actually we're electively delivering preterm babies more frequently. There's a lot of work to do in this service.
Sure.
I need some help.
Okay. Well, look, I definitely know some people who are good at analysing data on there, so I'll make sure that they may contact with you in the next
That'd be
kind of few
great.
days, and we can help that, and then maybe that can help us with that question about how we need to move the service on and support it going forward. So
Yeah.
thank you.
Thank you.
That's brilliant. Thanks, Day, and thank you, Martin, for that offer. Justin.
Hi, Day. Thank you so much for your presentation, and thank you for everything you do. I've been a neonatologist for almost 30 years, and I really was impressed by your book, which I've got a copy of. You can't see it because the way the screen works. There you go.
Yeah.
I think it's excellent. I think it's a really good resource for women, but I actually think it's a really good resource for clinicians as well. I guess one of the things that you sometimes don't get as a neonatologist is the perspective of the woman as they're waiting potentially to have that baby preterm. I think the work that you're doing in order to try and prevent prematurity is desperately important. But I also think the work that we're doing around optimization of those babies that are born preterm, we know that there are things that we can do now that we could not do 10 or 20 years ago, that very much changes the trajectory for those babies. But an additional complication is that we're now seeing babies who are born far earlier, 5. And that's also a problem because those babies will almost certainly grow up with some degree of morbidity. And that will be a lifelong issue for those families. So all of these issues are complex. And I suppose I just wanted to say a big thank you for the work that you're doing.
Thank you. It's nice to see you've got a copy of the book. That's lovely.
Lovely. Karen.
I thought that was a really interesting presentation, so thank you so much for that. It also has some personal overtones in relation to my grandchild as well, so it's an area that truly matters. What I really wanted to ask you is, what support would you most like from us as a board to actually help you with this work? If you can have just one or maybe 2 things, what would they be? How can we help you with it?
Oh, that's a fantastic question. I think the ways that we can move forward, one of those ways is sort of more community links. And I don't know how how the board can directly sort of liaise with that, but we do have our MNVPs. But as I say, like, I really think women's stories are the way to kind of push these things forward. So a project that I'm trying to kind of get off the ground with the region is embedding women's stories, sharing women's stories on all the platforms that we have, all of our social media, in women's stories, women from all over the world in different languages, sharing their preterm journeys and then using those to actually go, right, this is the care that we offer. This is what could be better. An area that possibly we could do more work in is preconception care and management. So we're getting these women early, enlightening them and giving them that understanding and perspective early, even before they're pregnant, so that actually if they've got that history and that background, we can do work with those women coming into pregnancy rather than trying to play catch up when they're already pregnant. And then our timelines are very short when women come into pregnancies with complex histories. We're like, from the time if they book early at 8 weeks, that's great. We can do more work, but sometimes we have to get cervical cerclage in by 12 weeks. And if they're booking at 8 weeks and we're hearing about them by 9 weeks, we're trying to get them in for blood tests at 10 weeks. We're trying to fit them into our very busy preterm clinics, in that time frame. We're already on the back foot. So I think more sort of community support, perhaps where, you know, we have affiliations with someone like myself being available once a month to kind of go, this is a preterm meet. So anyone who's got risk factors or who had a previous history, then we can use it as an opportunity to go, right, going into pregnancy next, this is what you need to be aware of. These are the risk factors. This is kind of where you need to be, optimizing your health and your well-being prior to pregnancy, booking early, accessing care early, getting the right mental health support early as well, because it's very triggering coming into a new pregnancy with loss and grief and all of that as well. So yeah, I think community liaising is going to be vital, preconception healthcare as well.
Great, thank you.
you.
And a great question, Karen.
Mm.
Zoe.
Thank you. What an inspirational lady you are. It's lovely to hear your story. I am one of the links with the University of Hertfordshire, and I'm part of the School of Health, Medicine and Life Sciences, where our nursing, midwifery, medicine and all the related are sitting there.
Amazing.
I really think that it would be a fantastic opportunity for you to start this story when we get the students. Because it's lovely for the users to have it, but we want the next generations as they come through to be. It means your book is going to go on reading list for all these healthcare professionals for sure. But more importantly, I would like to reach out to you, and I'm going to make a connection between you and the head of the department for midwifery and nursing, just to make sure, and of course for myself, for nursing and others, just to make sure that we see more of you. And of course, we've got the opportunity to link you into our research grant applicant, support that you might be needing for your funding, because it's a lot of work, and we've got a lot of expertise within the university that they'll be able to support you there.
Thank you. That is amazing. And that was one of the research proposals that I presented at Bradford, was actually how can we incorporate a resource like this actually into midwifery healthcare learners. And I've spoken to the colleagues at ARU, and they've put it, Anglia Ruskin University, they've put it on their recommended reading list. And I've offered myself to come and speak to the students, because this is where it starts. It starts with our students. We want to embed that learning. We want to embed that kind of emotional connection so that we've got more empathetic healthcare professionals coming in even before, they're qualified, to ensure that that's embedded, that understanding of the impact for these women and families. So yeah, I look forward to connecting with you.
We know where you work. You don't have to approach us. We'll come and get you. Don't worry.
Very good. And that would be a great connection. And I should actually have said, when you were answering Karen's question, Martin chairs the Healthcare Partnership for East and North Hertfordshire, which involves primary care and the Community Trust and also VCFSE. So I'm wondering as well that there may be, if that bit about getting to ladies perhaps before they've even started the pregnancies, that's in that sort of the health, population health piece and health, prevention of health issues. There may be something there that we can do at the HCP. So as Zoe says, we know where you live, so you won't escape as and when it's the right time.
Perfect.
Final question from Nina.
I'd like to also say thank you so much, Didi, for your work, obviously, and also for the presentation. It was amazing. And I think on a week, like you said, where there's been a lot of really milestone reports that have come out, it's really, really lovely to see the work that we're doing to help the mothers that are coming through the trust. What I wanted to ask you is two questions. So the first one is, in the example that you gave, obviously the second time pregnancy was monitored much better than it was the first time round. And I was just wondering, what do you think we can do to catch those women in the first pregnancy? And you may have answered some of that with your community answer that you gave to Karen. And I was just wondering, what can we do to make sure they're getting the right scans at the right time? And that it's right for every patient that's coming through, because often, as you said, the first pregnancy is the one when you're really nervous, you don't really know what the danger signs are, you're really kind of having to navigate through that. And the second one I wanted to ask you is, how do we make sure that we're breaking down some of the beliefs that we have ourselves about the mothers that we're seeing, such as the example that you gave around things like pain for Black mothers? I'm sure you're aware of, often South Asian mothers are called princesses when they go to give birth. So how do we as a trust break down some of those beliefs within our own organisation to try and serve those communities better?
Thank
It's a
you.
big
Those are
question.
great questions.
Sorry,
Yeah,
Didi.
big question. I'll do my best. So I think from the first question, you were talking about how do we identify, and this is one of the biggest challenges in preterm birth. It's not something we're going to fix imminently. I believe it's going to be a piece of work that's going to take us through years, because a lot of the women who have a preterm birth don't have preterm risk factors, actually. A smaller percentage of those deliver preterm when they're under surveillance, which is great because hopefully that means we're being effective. But most of the women who have a preterm birth don't have risk factors and they're first time mums. So this is where I think knowledge and education and that kind of surveillance comes into play. You were talking about how do we kind of offer them the right screening. There's some emerging research that's coming out about offering universal screening of cervical length to first-time mums, to everyone who's pregnant, basically, around the middle of pregnancy, to try and identify, can we catch any of these women who have a weaker cervix before they present to us too late to be able to support them. It's an ongoing piece of work. We're not kind of at the point where we can initiate that, but I think it's symptom awareness. I think a lot of the time, we need to be encouraging women about the risk of preterm birth. I think we don't talk about it enough, maybe because the percentage of people that it affects is not so high compared to other things, but the impact, both emotionally, psychologically, financially, I've mentioned all of that. But I think it comes down to giving women that information early, but maybe as part of the booking, then I think we need to build our antenatal education better. And there's a lot of pressure for midwives. Adding more things always feels very daunting. So I don't know where it's going to come from, but I believe that, again, we need to be sharing these stories about, oh, this is a first-time mum, no risk factors. We were able to catch it. We share the positive stories as well. We don't want it to just be a series of sad events that we're talking about. But it's like, this is how she identified that there was a risk of preterm birth. There was a change in her discharge. There was a change in, her abdominal pains. There was these changes. She knew where to go. She knew how to explain that to our healthcare professionals. We should be creating scripts for women to be able to help them voice their concerns. I'm concerned about my baby because the pain I'm feeling feels like this. We should be encouraging them, empowering them to be able to express that. We have a large population of people who do not speak English. We have a large population of people who cannot read or write. We should be doing this in video formats as well. We should be doing it in all different formats. It shouldn't just be, as nice as it is that I have written a book. It's a book in English. You need to be literate. We know the average national reading rate is, I don't know, the age of 10 or something like that in the UK at the moment. We need to be finding innovative and creative ways to get this information across to women. Social media is currently the biggest tool that we have available. And a lot of women come and say, I heard this on TikTok. I saw this on an Instagram. I saw this on Facebook. That's where they're getting their information from. We need to find a way to reach women in the most modern way that we have available. And that is through social media, through videos, snippets, animations, these kind of things, sharing women's stories as well. So that's what I think. And in terms of breaking down those barriers and for disparities, again, it comes down to exposure. So we're talking about women's experiences. What does good care look like? How has this woman experienced good care, and how should that be replicated in other settings? So that's what I think is the way forward.
Thank you so much, Didi.
Brilliant, thank you, Dede. I think there's lots of comments in the chat as well. Really, your passion just shines through, and you're obviously doing some phenomenal work for not only the trust, but most importantly for the mums and babies that you're supporting. So thank you for everything you're doing. Thank you to the team around you that I'm sure also support what you do. But no, that was lovely to hear from you today.
Thank you very much for having me.
Right, thank you. Right, let's move on then. We're going back to the normal agenda, and we'll go to Martin. Martin, the Chief Exec's report.
Yeah, thanks so much, kind of, Anita. It's a little bit of a longer kind of report maybe than kind of usual, but I find that I think you've already stolen some of my best lines sort of from the report, but maybe I should get used to that on there. I don't know. So there's obviously a few things I'd like to say as new chief exec for the organisation. As Anita says, a very demanding and competitive process, but I'm incredibly honoured and privileged to be asked to take up the role and help in terms of leading the organisation into the next stage of its journey. Undoubtedly, over the summer, I'll be spending a lot of time out and about in the organisation, kind of listening to the views of kind of our staff and also our patients in terms of where they find the organisation at the moment and some of the things that we need to move forward with. I think there are aspects of change on there, and I think as we come on to maybe our IPR report kind of later on, performance is an issue where we have several challenges as an organisation. Where I think we have an ambitious, we are collectively an ambitious board and are ambitious for the organisation, and there are some aspects of our performance at the moment where we do need to raise our game kind of slightly or significantly in kind of some cases. But I'll talk a little bit about that a bit later on. I think I'm incredibly grateful that kind of Teresa's taken up the post as deputy kind of CEO on there. I think that brings kind of great experience and gravitas to the role on there, and I really look forward to working with her on our joint agenda. And I'm also really glad to welcome Barry to his first board meeting as our interim CFO. So Barry kind of joined at the beginning of kind of June, and he's still here now. So I'm taking that as a good sign on there. So, but we have commenced a formal recruitment process for our new CFO. I do expect to have a good and competitive field sort of for that, and we'll be looking to make a decision around that in early September. In terms of just a few other things to kind of highlight, we did receive confirmation in early July in respect of our NOF rating, our National Oversight Framework rating for the Q4 period of kind of last year, and that has embedded a segmental rating of 2, which is very good and strong performance for the organisation across a range of different metrics within different domains on there. So that is good news for the organisation, and it's important to say thank you to everyone who's contributed to that delivery. But we do know that we are moving into perhaps a more challenging 26-27 sort of period, that some of the features of those rankings of performance will change, some of the thresholds in there, and we have some performance challenges around some of those areas as well. So we're going to need to double down on our efforts in there to maintain that rating. Anita has already kind of talked about kind of some aspects of kind of national reviews that have been published this year, this last month or so. I won't say any more about the kind of man review because Penny's picking that up a little bit later on the agenda. In terms of Ockenden, I think for anyone who's kind of waded through kind of Ockenden, we also have the Baroness Amos kind of report that's come out kind of slightly after that. Yeah, I think some really kind of stark and challenging, I keep using the word challenging, but it's definitely true, reflections on the delivery of maternity services at the moment and steps and improvements that need to be made across the NHS on there. So certainly as a trust, we're digesting those at the moment. As Anita's already reflected, there's 1 or 2 actions that we have to put in place almost immediately, and they've been deferred to quality and safety to take those steps or to ensure board assurance. But there's other activity that we need to move forward on at pace as well. So we'll bring to the September formal meeting of the Trust Board reflection on Ockenden and Amos, key learning points and key responses that we have in place as an organisation. I think it's probably just helpful to note that the consultation process in respect of the Mount Vernon Cancer Centre and its new location and transfer of service. We know that was a process of consultation that started in the late spring, and that did conclude in June, and we're very much into a process now where the outcomes and reflections from public and other stakeholders are being kind of digested and reflected back into the proposal on there. So we'll look forward to continuing to work with a variety of stakeholders, particularly NHSE, UCH, and colleagues across at West Herts as that proposition hopefully moves forward. I think it would also be really important just to reflect on Bedford rail crash train incident that occurred in the middle of June, and that was a very tragic and sad kind of event, and further reflections around the causation of that will be ongoing. But I think it is important to note the Trust's role in the response to that. I think the NHS delivered a hugely creditable and fast and responsive reaction to that event. And although we did take a few kind of minor patients from that, but what was incredibly important from an East and North Arts perspective is we stepped up to provide a fail-safe to relieve pressure on organisations that were at the very forefront of dealing with that, particularly colleagues at Cambridge and also Bedford Hospitals Trust as well. So I was really proud of the organisation and proud of the way that our teams kind of responded in that emergency. A couple of items there in terms of estates and capital developments. I think the board are aware of the challenges that we've had in terms of kind of Swift Ward and a business continuity incident in terms of our infrastructure that was identified at the end of April. That meant that we needed to close that ward for some remedial and infrastructural work. That has happened at an incredible kind of pace on there, and that ward is now back up and running as at the very end of kind of June. I think our estates team have done an excellent job in terms of doing that, and have done a lot of future-proofing work sort of in there. So that's good and that's important. But I think the main thanks are to our operational and clinical teams who've had to cope with the non-availability of 26 beds on Swift for a prolonged period of time. And that might not seem like a huge number, but it is in terms of a hospital that runs with very high levels of occupancy. So I'm really grateful for staff that have worked around that and made adjustments sort of for that. And then I think finally I'd probably just reflect on anyone coming to the Lister Hospital at the moment will see a big new building kind of rising from the plaza in respect of our new front main entrance. So that will, that work is happening at speed. So now and is expected to conclude in September, and that will primarily give both staff and patients and visitors to the hospital some opportunities in terms of kind of access to retail facilities that would be a significant kind of improvement. And that's a commercially funded kind of proposition. So no public money has been spent on that, but I think will be a valuable addition to our estate as a hospital. There's a couple of just recognitions there in terms of achievements for staff, in terms of kind of award kind of nominations, and also just a flag in terms of we have the Time to Shine kind of awards next Wednesday afternoon, which potentially clashes with a significant football event, I'm led to believe, sort of on there, but I don't want to mention that kind of too much because it might curse the outcome of that football match, and then of course we wouldn't want to do that, but it might give us a little bit of a challenge in terms of how we accommodate on the day. But I'm really looking forward to the Time to Shine awards. They're a really kind of important celebration. Often as a trust and as an NHS we focus on things when they're at their most challenging, but we need to also identify time to reflect on the many things that do go well in the organisation and the individuals that make the commitment to making that happen. So I'll probably apologies, Nita, that's probably longer than usual, but hopefully you'll indulge me on my first report.
I will indeed. I don't see any hands raised, and yes, you're absolutely right. You and I are going to fight over who can get to give the good news in these board meetings. And one of the ones I did give to you, but I did want to make sure it was a deliberate omission. I did want to personally welcome Barry Jenkins, our interim chief finance officer. I decided not to do it at the beginning because I wanted you to have the opportunity to introduce him. But we're delighted you're with us, and thank you, Barry, for. As Martin says, 1 month in and you're still here. That's good news. So thank you for that. Right, if there are no questions or comments, I'm going to move to the next item on the agenda, which is the staff survey, and that's Penny.
Thank you, Chair. So I'm very mindful of time, so I'll just do an overview of the slides and then focus on the real area of discussion, which is what do we do about the staff survey. So For those of you that have been here a while, NHS has an annual staff survey. We publish the reports in about March, April time. We discuss them, have an action plan. Board gets involved in terms of assurance and overview. This year, we've been asked to do something slightly different in addition to that, which is to look at the free text comments. So not everyone adds them, but to look at those that have been added and to pick out 3 key themes that staff and colleagues are telling us isn't quite working, and to focus our actions on those. So in the pack, what you have is an overview of the a couple of context slides of the survey itself, and I'll touch on that in a moment. And then particularly what I want to focus on in this is, what do the comments say and what are we going to do about them? So just a couple of headline figures then. So we had less in our last staff survey, we had less people completing the survey, about 10 percentage points. That could be a number of things. It could be people sometimes just forget, you get chase up emails, but people do just forget. And it could be one of the areas that we will be focusing on, which is workload. There is also mention in there about access to ways in which people can give feedback and actually complete the survey. Typically, it's online. And one of the things that we're talking about is how do we ensure that people have the time, but also the access so that they can share their views with us. The thing to bear in mind, I would say, and anyone listening, is that we don't just do this as a one annual event and that's it. We also have a number of different ways in which colleagues can share their feedback with us, and a number of different metrics that we look at to tell us when things are going really, really well and not so well. So I didn't want this to be, this is a one and done, it's an annual event. Actually, we have a number of different ways to keep in contact with how our colleagues are feeling. So moving on then to the ask. The ask was, what do the comments say and what are you going to do about them? So out of the 41% of our colleagues who filled in the survey, 23% chose to add comments. So we had lower percentage of people who completed the survey, and then just over half actually shared their comments. But what did those comments actually say? 3 key areas really to focus on. Unsurprisingly, the first is capacity, workload, burnout. And some of the things that the comments said is that people are not replaced. When they leave, we are often, what's said is we're doing 2 or 3 jobs. The recruitment freeze, and I reference that particularly because I'll come back to that in the actions. The recruitment freeze is really putting a strain on people, and we need to urgently review that. So that was the first thing. The first area is workload and burnout, and I've got a couple of actions that we've already started to implement, which I'll share with you in a moment, which hopefully will address those. The second area that came up in the comments was leadership. And we do have a number of different communication channels. What we're looking at is whether that's communicating with people in a way that they want to be communicating and receive information. Because one of the comments which really stood out to me was there's absolutely no communication between higher levels of staff and everybody else. Actually, there are a number of communication channels, but what this says is perhaps they're not the ones that people want, or they're not as impactful as we think they are. There was a comment, or there have been some comments about bullying, and I'll go on to talk about that when we talk about the actions. And the third area is what I've called hygiene factors. And in the pack, if you have access to the pack, it's called pay, parking and practical conditions. So these typically tend to be the environmental factors that can be quite small in some cases, but really irritating for people. And when you think about their experience of their work life, that can be really quite damaging to them. There are some that we can do something about, and there are some that we can't. We have finite resources. Parking is one of them, but we can try and make best use of what we do have. So I would just like to focus, if I may, on the actions, the so what. So we've looked at the comments. What do they tell us, and what are we going to do about them? So in relation to workload and burnout, it's addressing the perception of a recruitment freeze. We don't have a recruitment freeze, nor have we ever had one. And I think what happens is people get so busy, and we are very mindful, and we do scrutinise how much our workforce has grown and continues to grow. that therefore that then translates into there's a recruitment freeze. There actually isn't, but there is a lot more scrutiny around how we do things and who we ask to do things. So it's addressing that perception that there isn't a freeze. The second point to bring out, I think, is really, really important, and it relates to our 4 strategic goals. I think it is fair to say people are that they have a very high workload and they don't know what to prioritise, because when everything's a priority, nothing's a priority. If we go back to our 4 strategic goals, and we're doing this through a process called strategic cascade, which is talking to different layers of staff about what's important to us. It really gives a good anchor as to, right, okay, what are we doing here? What's our really important things to achieve this year? And if what you're doing doesn't relate to one of those, let's have a conversation about why it's a priority. So that's the way to address the workload and also prevent, hopefully, burnout. We have also shared recently at our trust partnership meeting, which is our meeting with staff, our staff side colleagues, trade union colleagues, all of the health and wellbeing options that we have available to people. So if they are starting to feel they need a bit of additional support, there's actually quite a lot out there, and we just need to make sure that people know that and can access it. And then the final thing I'll say on this, there's been a lot of talk about Grow Together. So Grow Togethers are our annual review, and it happens at the end of financial year. It's bunched up over a short period of time, and people find that quite difficult. So we are looking at the option of how do we kind of embed performance management in a positive way throughout the year. So have positive one-to-ones, have regular conversations, so it's not just a big deal at the end of the year, which actually carries quite a high workload. So those are some of the things that we're doing in relation to workload and burnout. In relation to leadership, I mentioned there that not every staff member, colleague member has access to some of the communication and leadership channels that we have. We have a leadership live every month. We have an all staff briefing, but it's online. So if you don't have access to that, you're not necessarily going to see it. So we're looking at ways at how we can make that accessible to everyone, rather than change the method of communication. It's how can we make this accessible to everybody? And also we've got a big transformation program underway at the moment, and looking at different ways to communicate with people, prioritising face-to-face as well. So how can we use team meetings, regular huddles to drop those messages in? So people on the wards, people who are portering, people in canteens, including people in the offices, all get the same message in a way that actually works for them. And then the final thing, hygiene factors. As I mentioned, some of the things that people raised in the survey, we can do something about, some we can't. We have got finite resources. But what we are doing is trying to make a really easy way for people to see what's available to them. In the same way that we're doing health and wellbeing interventions, we're doing the same for rewards, because we do actually offer quite a number of different types of rewards, benefits, discounts, travel schemes. If you don't know it's there and you can't access it, it doesn't feel like a reward. So what we're trying to do is to bring that together in a really easy way for people to access, so they actually become aware of what's already available. So I've spoken quite a bit there. So 3 key areas, 3 areas of actions that hopefully will address some of the things that came up in the comments. And we have a question.
Thanks, Penny. Richard.
Thanks, Anita, and thanks, Penny, for the introduction into this important theme. First of all, the way that the paper starts is NHSE has asked all trusts. And that kind of suggests we do this because NHSE asked us, but I feel this is a really, really important topic that we should be addressing, anytime, any year. Yeah, so it's really important. And my main question behind some of the observations reading the paper is really, are we listening enough to our people? Because I think a 600 less response, the 10% points you talk about, is a huge difference compared to last year. Some of the remarks related to leadership and communication are quite concerning. And when you look at the appraisal score, the 4.89 on a scale of 10, that's really concerning too. And so I'm wondering, and then when I look at the actions, and maybe there's a very detailed action plan I don't see, but the actions don't have owners, they don't have dates, they're quite generic, and they create an impression of, these are the types of things we're considering, but are we really doing them? And so the biggest question behind what I'm saying here is, are we sure we're addressing the root cause of some of these issues here? Are we really listening to our people and addressing what keeps them bothered?
Thank you. Anita, can I come back on a couple of those if I may? I'll be quick. So I'll start with the end. I think just the NHS England have asked us to do it. You're absolutely right. It's important. Excuse me. That was just to contextualise why we're doing something different. It's not because they've asked us to do it and so we've done it. You're absolutely right. It's important that we do, and we do actually look at the comments anyway. This is the first time I think we've shared it in this way because it's been a new ask. I think your point is well made about, are we doing enough to engage with people in a way that actually makes them feel safe to say. It's, you know, it's fair enough having an agenda item on a team meeting, but if people don't feel safe to say and come forward with their ideas, then perhaps it's been done, but it's not necessarily added value. So I think there's definitely something to explore in that. And the other thing was, you're absolutely right, it is fairly generic, I think, for this audience, but there is a plan that sits behind this. And then the final thing I'll say is on the comms, I think that's really been recognised that, let's say, a monthly Teams meeting or, you know, a newsletter or an email doesn't actually work for everyone. So we've got to understand the needs of different groups and meet them where they're at, rather than just the way that we want to comms out, if that makes sense.
I think that's helpful. I would say, however, and you know, and I'm glad Richard mentioned it, the drop in the response rate is extremely concerning. And I don't know, because I've not seen the data, where we now sit nationally, because times are tough for everyone, for all acutes in the country. If ours has dropped significantly more than other people's have, I think that says it is a specific problem for us. So it isn't in the pack, but it would be helpful for us to understand. If everyone's has dropped by 10% and we're in exactly the same place in the pack we were before, it's not good and we still have to work on it, but it's a different situation than actually everyone else has only dropped 5% and we dropped 10% or whatever it might happen to be. So it would be good to understand that context, I think. But let's move on. There are a lot of hands here. Thanks. Teresa.
Thanks, Chair. Penny, it's a really helpful read. I guess one of the areas that I'm really focused on and interested on is the raising concerns. So whilst we sit in the middle of the pack in the paper, there's clearly room for improvement. And I guess the challenges around freedom to speak up, but other avenues as well. And I think we have some solutions and some suggestions in the annual report, and some great work being done by the people team, and also by our supporting NEDs as well, of course. But I'm just keen to get your views around what could we do differently to move that score along so our staff feel that they can raise concerns.
I think it's definitely something that Martin's already kind of given us as a challenge, not just as an exec team, but as a leadership team, which is visibility, getting out more, speaking to people. I think there is something in the kind of formal, let's have a meeting about it. But actually, when you do the positive leadership rounds and when people see you, they trust you more, they're more likely to come forward and say, did you know? So, you know, I've got a very good relationship with our staff side, and often get, did you know, just giving you the heads up. That's really, really important. But also I think it's linked back to workload as well, Teresa, because I think if you were to ask many of our leaders and managers, why don't you do more of this stuff? They would say, because they don't have time. So I think there's a bit of, there's a number of things we could do and should do. But I think trying to create space for people to spend time on this, so it's not just another thing to tick off, it's actually meaningful engagement, which then builds trust and gives that person time to do something about it as well. So I think it's a bit multifaceted, actually. Starts with us, but not just with us. I think it's peppered throughout our leadership population.
Thank you. Next one is Nina.
Thanks, Penny, for putting this together. It's actually really great to see the information on a page and to get this through. And I had a couple of questions, actually. So the first one was around burnout, because actually that is what we are all hearing when we go around as well. And I think that is something, when we're trying to transform the way that we operate and deliver care, that is one that we do need to be obviously really wary of. And are we making sure that as we transform the systems, we're putting in place ways that we're going to reduce burnout and making sure that we're checking the temperature all of the time. So I wasn't sure how we're going to do that. I think the second one for me was around the hygiene factors, because I think the hygiene factors also include the health and safety climate, because actually that should be a basic, and also the appraisals, because we should be getting those things right. It goes back to the thing that Martin was saying at the beginning, you know, about making sure that we're getting the fundamentals right. And so I would like to see that kind of added into the hygiene factors. And I guess the same as everybody else, you know, there is something about how are we making sure that we are really hearing what staff are saying to us. I think, to be fair, I suspect that part of the reason why it might be lower is because we were going through a change of leadership at CPO level. And I know that Tom used to do quite a lot of work to make sure that people were, you know, signing up. And obviously that was going to potentially fall through the cracks, but I'm not sure if that's what happened. And I suppose for me, the other one is around that, you know, we've got compassionate leadership and culture as a high, but then we're also hearing that actually the leadership isn't listening to us. And that feels like a real disconnect. And it also feels like a disconnect from what I hear when I speak to my exec colleagues and what the organisation is feeling. And I just really wanted to know how we're gonna try and kind of reduce that, because that's not what I hear when I speak to people in the organisation. So that's obviously not coming through to the way that staff are feeling.
Yeah, I think if I were to use one word across all of the survey, it would be consistency. I think it happens in pockets, not everywhere, and it should happen everywhere. Your point on medical, on appraisals is well made, and it's actually a key part of we've now started performance senates, which are kind of monthly get-togethers to talk about performance, and medical and non-medical appraisals is what is high up on the agenda, because it's not just about, as I say, the end of year appraisal. It's really important, but it's also about the monthly check-ins, the how are you, you know, you don't look like, you know, you don't look yourself. It's just that gentle check-in with somebody. And again, goes back to the burnout. If you were to ask a lot of managers, they say, I don't have time, but actually that's the real nugget, and that's really important, where you start to get you start to hear the creaks before they actually break, and that's where it's really important, because you can do something about it. So it's a fair point. Thank you.
Right, I'm really conscious of time because we are already well over. So can I just ask the 4 people that are waiting that I'm going to come to, can we please be as succinct as possible in both our questions and our responses? It's all right, Penny, I'm not shouting at you, but it's just at all. But we do need to up the pace here quite significantly, or we're not going to end up getting a break or at all. Diana.
Thank you, Chair. Penny, I just wanted to ask that, given that we've seen, as you say, a drop in response rates from staff, from the areas that you've chosen to focus on, you know, workload and burnout being one of them, is it really representative of what we think is going on within staff that they genuinely believe? So, for example, are you triangulating that with other information to say this is actually the issue here, or is it something like workforce capacity, operational pressures? And if so, kind of what sort of root cause analysis have you done, and what are those things, do you think, or is this really what we're honing in on is correct?
Yeah, I think so. The triangulation of data is something that we present back to the people committee. So just in short, it's not just looking at one metric, it's looking at a number of metrics. What's it telling us? You know, staff complaints, patient complaints, grievances, absence, all that sort of stuff. That gives us a health of it.
For me. Oh, Penny, I can't hear you.
Am I back?
I think you're back. Please go ahead.
I can hear Penny.
Yeah. Thank you.
Yeah, I can hear Penny.
Okie doke. So just on that, in case anyone didn't, so basically triangulating different data sets, absence, grievance, staff complaints, a number of different things, gives us a health kind of check. So I think that's the first thing, is how are we picking up other metrics? And then in the people committee, what we've started to do is identify hotspot areas, perhaps where they're starting to fail, for want of a better word, or to highlight red in some areas, that we would go and do deep dives. We've started to do that, for example, in our high levels of sickness absence. You know, what's it telling us? What's going on here? Where do we need to really get under the skin of? So, as I said in the narrative, we don't just look at this survey in isolation in and of itself. We actually use it to with other data sets to kind of do some work outside of that. So I know it's a very quick way of answering the question.
Thank you, Janet.
Sorry, just turning the fan off so it doesn't disturb everybody. Yeah, just I mean, I know we're short of time, but I think for me, we had quite a deep conversation at the People Committee about the quality of Grow Together conversations, and the idea that it should also be that sort of, as Penny says, the kind of checking in. But there's something for me around, it's not just counting the number of people who have appraisals. What's the quality of that conversation? And then just the other thing to add was, I think picking up on Dedi's point when she was talking earlier, you know, storytelling. I don't think we make enough of storytelling in this organisation, and I think if we can get some of that storytelling out there, I think it will help people to feel they're being listened to, because to my mind, part of the reason for the drop off in response is related to the fact people don't feel that there's a feedback loop.
Thanks, Janet. Martin.
Yeah, I guess just a couple of quick points rather than kind of questions on there. So there is an NHS context in this, and we need to bring that here. Response rates across all organisations in the NHS have fallen very dramatically this year, and I think we're in line with that. I mean, Penny can check with that, but yeah, this is in the context of difficult settlements for public services, significant challenge around performance and delivery and productivity. All organisations are feeling that doesn't invalidate the survey results, but I don't think we're alone sort of here on there. But I think we need to remember the NHS kind of staff survey is a gift kind of to us on there. It's the largest staff survey anywhere in the world that takes place every year. It gives us a huge amount of contextual kind of data, and we ignore it at our peril, I think. I think the bit about kind of leadership and leadership kind of visibility, we need to be, when people talk about leadership on that, I don't think they necessarily mean the chief executive or the chief nurse or the board. I would say as a board team, we are incredibly visible in the organisation. I think they're talking about leadership at a different level, sort of in the organisation, about line management on there. And I think there is a challenge there. I think there's a bit in terms of, the two things can be true at the same time. So the organisation can be struggling with kind of burnout and intensity of workload. Yet the reality is we have more people working in East and North Herts than we've ever had at any point in our history. And you might say, we have some productivity challenges in that as well. But I think that comes back to, what is it that we're working on? How are we prioritizing that? The clarity that we're presenting into the organisation about things that we need to do and things that maybe are on a different order of magnitude on there. And I think that's obviously something for us as a board sort of team. And I think there is, we should recognise these messages that are coming through in terms of free text or general statistic. We do have a challenge with effective communication in the organisation, and that is in part will be helpful. Making change in that area will be helpful to us in terms of unlocking some of the other areas that we have kind of here. But we need to acknowledge that. So there's some important messages here that we need to frame into our change agenda.
Thanks, Martin. Claire.
So I completely agree with Janet, and I think we are there's something for us to consider around the quality of our Grow Together conversations, and we've done a lot of work around that strategic cascade and making sure that from floor to board we've got some real strong golden threads going through everybody that works in the organisation. But the quality of the conversation around me as a member of staff with my line manager is more important than just the number. And I think we've got something to consider about how we get that information back out of the appraisee, and almost immediately. And I'll be honest, I don't always ask at the end of a Grow Together conversation is actually, how was that for you? Has that done what it's needed to do, and have you got some value out of that conversation, or is there something in our documentation that allows for that conversation to maybe happen either after the appraisal or a couple of days later on some reflection? It might be just something we can consider. And regarding the burnout, I think we do have an awful lot of transformation going on now, and I think we know that that's going to continue for some time. And I think we are all talking about the communication that comes out of that to make sure that teams right across the organisation are understanding what's happening, the pace in which it's happening, and making sure that we try and avoid people doing duplication. And sometimes people feel better when they just know something's happening. And I think we're working really hard on trying to get that communication back out from some of those pieces of transformation work.
Great. Thank you. Thank you for that. So Penny, thank you for that paper. I think it was really helpful. It was a really nice summary, and I think it's obviously been very rich because it's posed lots of questions from board colleagues. Just to board colleagues generally, obviously the main discussion about this will be continuing as an ongoing basis on a People and Culture Committee. If people are interested, you are always welcome to attend those meetings if that would be helpful. Right. I regret to say that we are now 20 minutes over time. So I'm going to have to be pushing people really, really hard. And if you had 10 minutes before, you've now got 5. So please, can I ask everyone to take their papers as read, only highlight the key factors so that we can have a conversation. So again, please, let's just be really mindful of that. As I say, we've got a lot of time to catch up. So thank you for that. Man review, Penny, back to you.
Okay, so as you said, Chair, I'll take the paper as read. The paper actually contains some information about what we're currently doing in relation to the Man review and what we plan to do. But just for anyone listening, hopefully you will have seen in the news, government asked a chap called Lord Mann to do a review of the NHS, started in October. Looking at anti-Semitism, but also systemic racism more broadly, published a report in May, June time, which said, yes, did find some areas of systemic racism, and then gave us a challenge as trusts and as healthcare providers to do something about that. We have an EDI strategy, an existing one, which has allowed us to kind of explore some of these areas pre-Man. What we're now doing is looking at whether we're doing enough. Our strategy runs until 28. We continue to review it. Diana kind of chairs our EDI board. And it has allowed us to look at the Man review, I suppose, with fresh eyes. Someone's come in and said, look, you could do this differently. 3 areas that the Man review has asked the NHS to commit to. The first, which is in the pack, is are two definitions. One is about anti-Semitism and one is about anti-Muslim hate. We've discussed that at People Committee and decided, yes, it's a request for a definition. It's more than just, yeah, we'll build it into policies. It's how do we talk about this? Going back to the previous conversation at the staff survey, how do we enable people to feel safe to say, I'm not really sure this is working for me? The other area is also about our patients. So this is not just about staff, colleagues, it's also about patients. And the Man review found that in some cases, people didn't want to use the NHS services because they didn't feel safe to. So we have a double hit there in terms of how do we create a safe space for our patients so that they come and use our services when they need it, and how do we create a safe space for our colleagues as well. There are a number of things in our EDI strategy, as I said, that we're already doing, and there are a number of things that we will continue to do. It's certainly not a complacent kind of we've done this, we're doing this, there's nothing to see here. Often when someone does a review, a bit like the Dido Harding one earlier, it just gives a fresh eye perspective of how we think we're doing versus how we're actually doing. And we'll be looking to kind of refresh our strategy moving forward. I am really mindful of time, and equally I'm really mindful this is a really important point, so I don't want to downplay it by saying we've done it and we're doing it. Needless to say, it's something that will continue, and to answer Richard's earlier point, there will be a plan that sits behind this of what we're doing and when we're going to be doing it.
Brilliant. Thank you for that summary. Justin.
Thank you, Penny. And I really welcome the 3 affirmations that are on the slide, that we're signing up to the things that Man said that we should sign up to. I think it's absolutely the right thing for us to do as an organisation on a personal level. I also really welcome it. One of the things Man commented on, but is not in this paper, is the wearing of political badges whilst at work. I think it would be really good to have a very clear statement as an organisation as to what our view is for staff when they're at work wearing badges that suggest alliance to one political group or one national or racial group. And I would really support something that also gave a very clear statement on that.
Thanks, Justin. You're absolutely right. And actually, the MAN review does contain quite a number of recommendations. I've had to distill it down for this presentation, but you're absolutely right. It's not just those three things. They were the three things that they really wanted us to make a public declaration of. And a bit like the conversation earlier, NHS England have asked us to do it. We are looking at all of the recommendations and seeing where we can embed them. So you're absolutely right on that. And I'll make a note on that. Thank you.
Yeah, that would be really good. Thanks. Richard.
Yes, and thanks for that again, Penny, and thanks for the remark about the detailed action plan. I don't need to ask that. That's perfect. Can I just confirm that we have formally adopted the definitions first, so that we have a very clear statement as a board? Yes, we have formally adopted the definitions. Secondly, do we have any local data on incidents in the past related to those different target groups that we kind of base some of our own action plans on? And if we don't have that data, I'd argue that maybe the assurance rating is not substantial but reasonable.
Thank you. Yes, we do. In some of our data, so for example, grievances, we do explore the reason behind it, but I think there's probably more to be done on that. As I said earlier, there's a triangulation of data. I think we've probably focused on one subset of it. There might be more that we can do in different subsets and then bring that together. So I think that's definitely a follow-up rather than a done.
Thank you. Diana.
Yeah, well, it just picks up the point that Richard has made, actually, because in People and Culture, we did talk about the fact that we do need to do a lot more in terms of the analysis and for the implications of the recommendations for the MAN report. And because we're still collecting that information, I think at this point, I'd agree with Richard. I think it's a reasonable rather than substantial assurance.
Right, thank you. Martin.
I guess it's just reminding us that there is some stuff that we formally need to agree here at the board. I mean, Stuart, he was right, kind of here on there, but from an NHSE perspective, there is that question of that the board is formally adopting the two definitions that are raised, and I think we need the formality of agreeing that and kind of communicating that as well. And I think there's also, I think, Penny, that it might be helpful through people and culture, that there's also a series of other commitments that we need to make at various times, whether that's around kind of the board undertaking anti-racism training as and when NHS England finally kind of define that, just so that we've got clarity in terms of not just what we're signing off now and agreeing to on there, but also other staging points that we have to make commitments to as well, because it's a very formal and very specific series of asks for us as a board.
Yeah, thank you. And that, Martin, that was actually the point I would have made, is that it's a bit about, and in fact, Reed has just made it in the chat as well. I think the thing about making some very clear commitments and very clear statements publicly, so that our staff, our patients, our users all know exactly where we stand and that we are signing up to this. The paper has come with a proposed assurance level of substantial. We've had two voices that have suggested that actually, given that we probably don't have the triangulated data at this point, that a reasonable would probably be a better assurance level. Can I ask, please, for some nods? Are we saying that we would prefer to reduce the assurance level to reasonable? Several nods here, several nods. Okay, we will then say that this is reasonable, subject to this additional data that will hopefully, the next time we see this, we'll be able to go to substantial. Thank you very much. Right, conscious of the time, can I please ask us to have, and I do mean a 5-minute break. We will start back at 11, so literally a bio break, as some would say. Please come back here at 10 past and we will kick off with the board assurance framework paper. Thank you very much. Right, it's 11:10, so welcome back to after the break. There's a couple of people that are still to join, but I'm sure they'll be with us very quickly. So let's kick off. And Stuart, it's the board assurance framework again. As I said before the break, can we keep everything as tight as we can? Thanks.
Thank you. So presenting the first versions of the worked up BAFs for review and feedback, recognising as first versions, these will be reviewed and refined in light of lead committee feedback, noting FPPC feedback was after board paper finalisation, but has been noted. The main message is the hard work starts now in prioritising reducing down these risks. So opening up for feedback and questions with a reasonable recommendation, reasonable assurance recommendation, and please ignore the partial tick at the top of the cover sheet.
Great, thank you. Does anyone have any questions or comments for Stuart on this paper? We have had some discussion about the wording of some of them in recent weeks, as board colleagues will know. So hopefully none of this will be a surprise. Richard.
Yeah, maybe a few remarks. I think there's still a few corrections to be done, Stuart, on this one, because in risks 3 and 11, there are closure actions in the past. I think the risks that are allocated to the digital committee need to be reviewed by the digital committee still. As you said, FPPC has reviewed, but it's not been incorporated yet into this paper. So I'm just asking, reasonable, is it reasonable, or should it really be partial at this point in time, noting that the actions still need to take place?
Does anyone have any comments on Richard's comments? It is proposed as a reasonable. The suggestion from Richard is that we should reduce that to partial. Janet.
I would agree with Richard, actually, because I think certainly from my perspective, it still feels like there's quite a lot of discussion needed.
Okay, we've had 2 voices to reduce the assurance rating to partial. Would anyone else have a view either in support or indeed to maintain the reasonable level? Okay, so can I take it? Can I please have some nods? We propose that the assurance level is reduced to partial. Is that agreed? Nods. Okay, thank you, Stuart, and I'm sure we'll see it back in due course. Thank you. Right, moving on. Learning from deaths. Justin.
Thank you, Anita. 2 main comments to make this month. All 3 of our measures remain below what would be expected, but there has been a slight rise in the 12-month HSMI measurement, but we've also seen corresponding drops in the HSMR and the crude mortality, and it's not unusual to see different things in different lines, as all 3 measures reflect different time points. And the chart on page 86 of the pack shows that over time, the overall profiles for all 3 are stable. There are 4 3-standard deviation outliers this month that I just want to draw to the committee's attention. They're all in baskets, which we're reviewing. The renal outlier reflects our tertiary renal unit, and it is not a surprise, and it is something we've seen before. Cardiology is a slightly different story, and it's probably to do with attribution of cause. So we see significantly lower deaths in, for example, our heart failure groups, but we see higher deaths in these 2 relatively small baskets. And therefore, again, although we're reviewing it, I'm not particularly concerned about that. There is a slightly increased death rate for non-Hodgkin's lymphoma, and that's something that we're looking at very carefully, because that's not something that has picked up previously for us as a trust. So we're looking to see if there is an error in coding, whether it's real, and if it's real, what it is that lies beneath it. Again, it's a relatively small basket, so it's fairly easy for it to get to 3 standard deviation outlier level, but we need to understand it fully. And I'll stop at that point, but I'm really happy to take any questions that anyone has.
Thank you, Justin. And it was a very clear paper, so hopefully everyone has understood the key points from it. Nina.
Thank you. I think one of the questions I just had is around, it feels that maybe for us, HSMR is starting to not necessarily be the right thing to constantly monitor because we always sit slightly below. And I know that we collect registry data, audit data. We've got a lot of other data, and it feels like maybe we should be really pushing forward now, starting to triangulate some of that information, starting to collect proms, because actually it's wonderful that we are constantly at a really great level. But also I feel like we need to start challenging ourselves now to really look at other ways to maybe use the other data that we're collecting and collecting more relevant data maybe.
Yeah, no, absolutely take the challenge, Nina. Perhaps we could have a chat outside of the board, some of the stuff that you're thinking about, and perhaps we'll bring Sarah into that discussion as well, and Mark, who leads on mortality from a medical perspective. I think there are an awful lot of places we could go to for the data. We do meet regularly with CHKS, who are our data suppliers, to look at what the options are. And we've also met with one of the other providers of data fairly recently to look at whether they could offer us anything additional. The thought was at the moment that they couldn't, but I'm really happy to sit down and go through, because I know there are a number of other measurements that we could look at. And you're right, it's great that we're doing okay with these, but how can we challenge ourselves?
And my other thing was just around data quality, because obviously because we're doing a lot of block contracts, so we're also making sure that we're still coding effectively. But that was my other thing.
No, we haven't changed our coding or our guidance around coding. And that's really important, because actually this data becomes meaningless if you don't do the coding properly. And it's reassuring when we're going back and doing coding reviews. For example, when we get a 3 standard deviation of outlier, actually the coding reviews are usually pretty accurate. So we're lucky, we're blessed with a really good coding team at the Trust.
Thanks, Justin.
Thank you. Richard.
Yeah, Justin, thanks. And it's a very clear report. I was just wondering, the increase in alerts, HSMI alerts from Q3 to Q4, is that concerning? Do you know why the increase, or
sorry,
should we not be
Richard,
concerned?
Are you referring to the 3 SD outliers, or are you referring to something else? So really difficult to say you're not concerned when there are 3 SD outlier for mortality. I think there is an explanation for the renal subgroup. I think there are good explanations for the cardiology subgroup. The group that I'm concerned about actually is the NHL group, the non-Hodgkin's lymphoma group, and I need to understand more about that. And that's a piece of work that's being done at the moment to understand better. Is this a statistical quirk? Is this something that's happening because of the way stats work, or is this a real abnormality, and is this a real problem and something that we need to deal with? So I guess it's about trying to go from statistical information to work out whether this is real and whether we have a problem or not, and that's the work that's going on at the moment.
Thank you. Diana.
I just wanted to pick up the point that Nina made, which I agree with, which is about the fact that we do have good quality, data now. So can we start analysing it, but also actually sharing it with, other areas, divisions, or with colleagues, just to see what we can learn. So from my perspective, I'd really be interested in knowing what the trends or the themes are for patient and carer experience, or for EDI, for example. So these are the kinds of things I think would be really excellent.
So we already do that. So our mortality committee goes through this data before it comes to quality and safety committee, and our mortality committee is made up of clinicians from across the Trust. So this is not data that we in any way hide. This is data that's shared openly with the whole organisation. But we also then take a summary of this data to what we used to call our rolling half day, so that every department within the organisation has their data and is able to look at it. I think the other thing is, because we use Power BI and we have so much of our data based on there, anybody within the organisation can look at that data. Anybody within the organisation can work with that data. So I would argue that we're quite an open organisation in terms of who has the ability to see the data. But I would also argue that we go further and we make sure that individual specialties are looking at the data. So I would expect every single team to look at this data within their morbidity and mortality meeting. And I know that that happens across the organisation. So I have a reasonable amount of confidence that the data is being looked at and the data is being used.
Right.
So
I
then
guess
think
the bit of Diana's question that it is about what about patients and carers, which I guess
Yeah,
as we work, as we start to work on what that model is going to look like, I would agree with her that actually it would be something that a summary of that going to the representatives on that committee would seem to be a sensible thing. So I think that's what Diana you were about to say.
Okay.
Yeah, exactly. Plus other issues like EDI, for example, those things translating across.
Yeah. Agreed. Okay. And last question, David.
Thank you. Obviously, QSC does scrutinise this every quarter. I find it an incredibly assuring report, and so does the committee. The process by which the clinicians engage at the mortality review group is also very reassuring. My only comment is, and I agree with you, Justin, that the cardiology data is almost certainly nothing to worry about. However, cardiology has popped up off and on for as long as I've been in the trust. So can we do something preventative just so that it doesn't keep coming up and you don't keep having the same conversation about it's just a numbers thing? I know that I have seen the clinicians, turn over every stone on this. So I am assured that that it doesn't reflect anything. But if it doesn't reflect anything, can't we get rid of it?
I'm really sorry. I don't think we can get rid of it. So there's a table that is not in the report that you've seen today, which is in the larger report that goes to Mortality Committee. And what that table shows is what the expected deaths would be for each diagnosis compared to what the deaths are for each diagnosis. And when you look at that table and you look at our larger groups, such as heart failure, you'll see that the trust has significantly fewer deaths than one would expect. I'm going to go slightly out on a limb on this and argue that the level of complexity we get to with our coding, which I see as a real positive, is the reason why you're seeing these baskets. It would be much easier to code and say this is a cardiac situation. This is because our coders go into so much detail. I think to some extent that then drives what you're seeing in terms of these 3 SD outliers in areas that overall are underreported, have less deaths than you would expect. So it would be nice to get rid of the 3 SD outliers, but I'm not sure it would represent a step forward for us as an organisation to do so. Sorry.
No fair comment. I would, and I think Nina mentioned it earlier about the necessity of good coding. I think everybody I see on that committee understands that coding is the core and probably responsible for 90% plus of the outlying explanations. Thank you.
Nina's just sneaked in quickly, very quickly, Nina.
The only thing I was going to say around the coding is that actually the risk adjustment should account for the fact that the coding is really good. So actually, if they're risk adjusting properly, then the fact that we've coded those risks shouldn't really impact the number. That's why I'm just.
Yeah.
But anyway, sorry.
Let's have a discussion outside because I have a slightly different view, but let's discuss it outside.
No, that's fine.
Yeah.
Sorry, Justin.
It's good.
Thank you. Right. I think we've all commented that it's a very clear paper, and it is proposed an assurance level of substantial. Are we comfortable confirming? I'm seeing lots of Nods. We're happy with substantial. Thank you. We will approve that assurance rating. Thank you. Moving on then. Freedom to speak up. Well, first of all, before that, the good news is we've managed to make up 10 minutes, but we are still 10 minutes behind. So can I please again continue to say, can all speakers treat the papers as read and only highlight the key thing so that we can have some questions, which I think is the most important bit. Thank you. I'd like to welcome Sylvia, our Freedom to Speak Up guardian. Sylvia, over to you.
Thank you, Chair. I'm going to take the paper as read. This is our 4th year of consistent rise in Speak Up cases. We have had a diverse group of staff across 10 sites, across the breadth of grades, speaking up. The key achievements that I would like to point out is that we now have a diverse group of 45 Speak Up champions across all staff groups. There's a rise in speaking up cases from our colleagues from every staff group, reflecting our diverse workforce and representing breadth of grades and seniority. There were only 2 anonymous Freedom to Speak Up cases last year. Now, I would ask the board to consider this alongside where a large group of our colleagues were going through consultation and were really frightened of losing their jobs. So if you consider that in context, it just gives us that assurance of how empowered our staff feel to speak up. We, as the Freedom to Speak Up service matures, I think a strategic alignment of Freedom to Speak Up with the other organizational drivers is really important now. I would, as part of our improvement, would like to suggest duty of care towards colleagues who have come to harm due to actions within the organization. And I would like to suggest that the organization consider formally acknowledging the harm caused, share learnings, offer an apology to colleagues who have suffered harm. And this is primarily to promote restorative healing. I would like to suggest that our leaders access mediation very early. We have got 8 trained mediators within the organization. However, all of them are based within the people team, and it would be beneficial to have a more diverse pool of trained mediators. And I'm going to stop there, and I'm going to let Teresa come in. Thank you.
Chair, I'll be very brief, just in support of what Sylvia is saying, but I think what this report does is it really plays to the impact that this board wants to champion transparency, listening to staff, and really acting on the messages that we learn. And there's a real read across to the staff survey in part that we heard about earlier. A couple of quick points from me, really. One, with the board's permission, we'd like to take the recommendations away and work through the various committees to come back and provide high-level assurance to the board that we are doing what we said we would do. And I would like to thank Dana and Sylvia for their leadership in this area, but also our chair, Anita, who has been exemplar, I think, in making sure that staff and patients' voice is heard at every opportunity. 2 quick points from me, finally, if I may. Freedom to Speak Up business is good, it's lively, it's perhaps too lively in some areas, and we've got to get into the detail of understanding how and why that's happening. And also, Sylvia's doing a sterling job, but she's a single individual trying to hold the confidence of many, many individuals, and that is a really onerous task. So thank you to Sylvia for doing that, but we've got to look at a more sustainable support mechanism, and Sylvia, you're working on that. And I guess 2 final points from me. You will see that internal audit provided a recommendation of reasonable assurance for our processes around Freedom to Speak Up, and I think that's highly valuable. And the final point I'd like to make is these are the cases that we know about. I think the challenge that we've heard across the board today, and I think Richard's point was beautifully made, is how do we get to every single service, and how do we get to the staff that don't have access to digital systems, that perhaps work out of hours, that are perhaps too sort of nervous to raise something simple that could be an obvious concern or something more complex. So that's part of our challenge, Chair, that we'll take away.
Thank you, Teresa. All points well made. Richard.
Yes, thank you. And thank you, Sylvia. I think you're doing a great job. And I think by looking at the numbers, we can see that that it's working better. Although, let's say, the increase in the amount of cases brought forward also brings the question of, well, why is there a reason to do it? And so I want to kind of go to two questions really. One is 70% of staff who came to the Guardian had already spoken to their manager. And so clearly there was no action, there was no trust, there was a reason that they didn't believe it was action. And my question is, what are we doing about that underlying cause? And then the second point is, of the 15 bullying and harassment cases, 5 colleagues left because they didn't trust the investigation process, the way I read it. And what are we doing about that? Because those are, for me, those are serious things.
Sylvia, did you want to come back on that?
Yes. So the first question around colleagues approaching their manager, which is what we want, speaking up to be business as usual, and them perceiving either their voice was not heard or they didn't have any meaningful action. And so one of the recommendations I'm making is that individually, any colleague who line manages another colleague, that as part of their grow together, they have a conversation around what support they need to listen up. Because I think this is the crucial point, how they are listening up and how they are actually understanding things from a different perspective. Sometimes as an organization, we have to move forward with the streams of work that we are committed to. The challenge is, how do we take people along with us? And I think there is more training needed to have that meaningful conversation. I hope that answers your question.
It does, Sylvia, but my question would be, how can we be assured that this really happens?
So at the moment, the fact that 70% of our staff have already spoken up to their line manager and then have access freedom to speak up, I think we can accept the fact that this is perhaps not happening as good as it should. My recommendations do ask that managers have more specific training around listening up and having good conversations. So this is something that we will need to monitor.
Thank you.
So are we monitoring, maybe Penny? And if so, do we then also check in on how effective this is?
I think the short answer is no, and I would go back to what Sylvia said. The fact that we do seem to be doing stuff, but it doesn't seem to be working. Otherwise, you wouldn't have such a high number. So I think the short answer is no. But I think, Sylvia, you've been starting to look at, and you mentioned it there, Teresa, about an action plan as to who's doing what in relation to taking some of this stuff forward. But I think the short answer is, if we are doing it, it's not enough.
Thank you, Penny.
Chair, may I just come in here?
Please.
So one of the actions, and this is also an action that is coming out of our internal audit, is that I think the way you strategically link in freedom to speak up cases, so that there's discussion at the People and Culture Committee. Actually, that would be a good starting point to take things forward. Thank you.
Great. Thank you. Diana.
Just wanted to quickly say just a big thank you to Sylvia and actually the champions for all of the amazing work that they've been doing. And just to echo what Teresa said, really, is that we need to look at the actions, we need to look at the recommendations in detail and to really thoroughly go through them and see, what sort of things we can do. And to pick up on Richard's point, I mean, there is a meeting that is planned to have a more detailed discussion about strategically how to align freedoms to speak up. So I'm sure that we will be coming back to the board and reporting on how we're tightening the process.
Thank you, Diana. Teresa.
There's a couple of areas I think that have been touched on earlier. I think we need to get into the realm of a wee bit more not being afraid to have mediation across the staff member and the manager or whoever it is, and not see that as punitive. So there's an education piece, and I think that's what Penny was alluding to as well. And I think we also, the really serious cases, we must, as an executive and a board, have a line of sight into those. And then if I was going to be really provocative, I would say we should look to resolve some of these complex cases and invite those individuals, if they feel comfortable, to come to private board and tell their whole story, because that's how we'll really learn.
Thank you, Teresa. Good points. Right, the next three, please, as quickly as we can. Penny.
Thank you. It was just to come back on Sylvia's point there about we already are starting to include the FTSE data into our people committee dashboard for hotspots area. So it's that, I know that I keep using the word triangulate, it's the triangulation of data, because you do get a number of different data sets that tell you you've got a problem. FTSE is one of them, grievance, absence, or sickness. So we've started to do that now, and that will continue to get monitored at people committee.
Okay, thank you. We are actually, I think, I'm not sure I can take both these. Since I think we've heard from Nina, I'll take Janet's, but Nina, I think I'm going to have to leave it. Sorry, Janet.
Yeah, I'll be very brief. I do agree that having some specific training and discussion about encouraging people to speak up would be beneficial. But I guess for me, there's something around the business partners, particularly the people business partners, really leaning into areas where managers are not listening, because actually if they're having people speak up to them and they're not listening and they're already in a managerial role, one has to ask, what's going on there. And so I think that stronger link that's been referred to between how the people team works and how the freedom to speak up function works is going to be one of the most powerful drivers to really embed that change.
Yeah, absolutely. I think just to wrap this one up, I mean, first of all, thank you, Sylvia, for an excellent paper, and thank you for the outstanding work that you are doing as a Freedom to Speak Up Guardian. I think, as others have said, we know what an impact you're having. I personally take the increase in the number of concerns, but only 2 anonymous ones. Actually, I think that is a real positive given the context that we are working in and the environment that our colleagues are working in, and the recruitment of new champions, the diversity and the spread across sites and roles and divisions, etc., is all really, really positive. So thank you for that. But thank you for everything you've done. But I think, as these questions have highlighted, now we've got such a good basis. Now is the time to really move it even further and deeper. And I think there is absolutely something about if 70% of people are still coming to you despite having spoken to their managers, that thing about do our managers have the skill sets they need to actually deal with this stuff must be the obvious thing, which, as Penny and Janet and Nina and others have already alluded to. So I think that's a very clear way forward there. But thank you for your work, and thank you for coming along today, Sylvia. Right. Moving on then to the integrated performance report. We are now we are now 12 minutes over. So Kevin, I think, is going to be presenting the report today. Kevin, I know you will have prepared a really good summary, but can we please keep this as punchy as we can? Thank you.
I will indeed try to. As you can see, the number of red marks all over this that I've got to cut out. First, I'd like to thank the divisional teams for their patience and support in pulling this together. They're trying to get a summary of what is very detailed information. So I'm going to dive straight in. On quality, the clinical quality remains stable through the month too, as it's identified. This is consistent with the expectations that we all have, because normally it would only be monitored through routine surveillance, and it would only change if unwarranted variation or emerging safety concerns were identified, and that hasn't been the case. So I think that's a fair identification. No concern has been identified on the overall position. With regards to patient safety, there is an identification in here of that we had 5 patient safety incidents investigations in in May, which is true, and the average over a year is normally about 12. So we're at 7 in the first quarter, which is higher. We think that's down to acuity, and some of it is in the maternity area. Having said that, in June there were none, so there is a fluctuation there. So it needs to be monitored and checked. The incident reporting, picking up on the incident reporting for medical records and obstetric services increased during May. The last time we talked about the issues of the medical records performance, which was at 53%, that has now raised to 93%. Whilst that wasn't the marginally below trajectory as we are, continued improvement is anticipated, and further assurance will be provided in subsequent meetings. So there has been a massive change in that. I know that Justin picked up on some of the stroke care and the VTE. I'd just like to identify the work on the compliance with VTE risk assessments improved approximately 60% last year to achievement of the 80% organisational targets that needs to be identified. And sepsis, a targeted improvement programme continues to strengthen compliance with the sepsis 6 bundles, particularly fluid balance documentation. And those improvements in actions included monthly data monitoring, local education, real-time clinical feedback, and enhanced digital documentation. So, and the emergency department has transformed to the iPad documentation. Work is taking breath to ensure that digital fluid balances are mandatory when sepsis pathways are initiated. So, good control there. Surgical site infections. There have been a number of issues around surgical site infections, and comprehensive patient harm reviews remain underway involving the infection prevention, microbiological, surgical teams. However, to date, there is no direct relationship that has been identified between infection rates and environmental factors, despite the initial fears. Detailed root cause analysis continues and should be updated after that. And further organisational learning is expected over the coming months due to the complexity of some of the individual patient reviews that have undertaken. Moving on to operations, the overall position in operations continues to improve across a number of the national standards, despite our ongoing capacity pressures. Number of targeted improvement programs begin to demonstrate encouraging early indicators. So we pick up on things like cancer performance. I think it was picked up earlier. We're ranked 14th nationally during April. Faster diagnosis standards recovered to 79% in June, following a temporary decline in May. And this demonstrates recovery in diagnostic pathways and continued improvement over the recent months. I'm just moving through. Diagnostics achieved their strongest monthly improvement in more than 12 months. The DMO one has gone from 50 to 45. Took me a little while to get used to the fact that it had to go down to be good, but it has gone down to 45.2, supported by the completion of the audiology capital works and the operational improvements across diagnostic services. So there are springs, the green springs there. I'll miss out on the RTT because I think that was picked up, but nationally the trust is ranked 35 out of 118 in the RTT. So I think that needs to be identified. Although there's progress and more work to be done, it needs to be identified that we're there. Community waiting times continue to reduce. We are continuing to work to continue to reduce community waiting times through Hertfordshire, integrated children and young people's neurodiversity pathway. It remains an important component of the Trust's wider access improvement strategy. Urgent and emergency care performance relay still remains below planned trajectory, primarily reflecting the loss of capacity associated with the closure of Swift Ward. There is work ongoing at the enhanced collaboration of primary care, East and Hertfordshire Community Trust, the implementation of call before convey pathway, front door streaming and redirection, introduction of the acute physician in charge APIC model, and continued pathway redesign and multidisciplinary working, all of which are showing improvement. But again, I think there is still some concern about the speed of that improvement. The Trust is 53rd out of 118 organisations for 4-hour emergency department performance. Puts us in the middle of the pack, but it's still not where we want to be. Moving on to finance. Again, I'm trying to catch out there. The financial performance remains the Trust's most significant organisational challenge. We're still reporting a year-to-date deficit of 6 million against a planned deficit of 5.3 million. I believe that some of that can be attributed to the industrial action, which I think was in the region of about £500,000. However, it is still on the edge with regards to our performance. We have identified a fully developed 37.9 million cost improvement, and that's being strengthened through enhanced grip and control processes, increased scrutiny through the recovery and control programme, and stronger executive oversight. It might be a little bit early to provide complete assurance on any of this, and I don't think anyone here would do that. But we've clearly identified a delivery trajectory extending across the remainder of the financial year. and that is supported by the appointment of our dedicated transformation director, additional transformation capacity, Deloitte and Changeology support, enhanced program management office, PMO, and knowledge program office, the KPO. And I believe that the Chief Financial Officer and Transformation Director will provide monthly reports on board on transformation delivery and SIP performance. The risks still remain, the financial high risks still remain around nursing, medical workforce, cost pressures, divisional overspends, temporary staffing expenditure, elective productivity gaps, planned care and outpatients activity, and individual service deficits, some which may have been historically masked by block funding. The financial priorities, I believe, the executive focus during the remainder of 26-27 will be on the delivery, of course, of the £37.9 million SIP, transformation savings, strengthened financial controls, elective productivity improvements, and monthly board assurance regarding financial recovery. Moving on to people, overall position of performance remains positive with regards to people. Retention and temporary staffing all performing better than the targets. The stability here is still stable. It's 7.3%, which is very good, and only 0.2 above the previous month. We're still below the average where we stand at the moment. Temporary staffing, bank expenditure has reduced by more than 2%, and agency utilisation has reduced by 0.7%. Representing its lowest level. It's going to be smaller and smaller, of course, because we've got the low hanging fruit, and now we're into the situation of the lowest level in 2 years, and it's going to become more and more difficult. So while 0.7 doesn't sound impressive, I actually, looking at the figures as I went through, I think it is extremely impressive because there were large drops. Appraisals we've already spoken about in the meeting. They are still red, and statutory and mandatory training, it remains red. However, on a personal basis, the possible requirement of people to go to some of the mandatory and statutory training, because it's a block, and I think it's the appropriateness of some of those training courses, which I think is actually skewing. I said this yesterday, is skewing the numbers, and I think a piece of work on there might actually reduce that number down, and not through doing it through a sleight of hand. And sickness absence is improving trend since January of 26. Stands at 4.4 as the lowest level since April 2025. The Return Well-Being Programme launches this month, and that will support earlier intervention and improved attendance. Vacancy rates on recruitment remain at 2.2, constantly below our target, 2.2%, constantly below, and improvements are continuing through focused recruitment campaigns, improved interview processes, stronger alignment with the inclusion of an EDI, and enhanced candidate experiences. Only one staff suspension remains open with a clear resolution plan at the moment, and policy compliance currently stands at 93%, with 4 remaining policies progressing through trade union and the LNC. So overall assurance, I hope I do people justice when I actually summarise this from this. I believe the Trust continues to demonstrate stable and improving performance across quality, operational delivery and workforce management. Clinical quality indicators remain stable. There is no evidence of deterioration in patient outcomes. Whilst targeted improvement programmes are delivering measurable benefits across stroke care, VTE, compliance, diagnostics, medical records performance, workforce stability and temporary staffing. Operational challenges remain, particularly within urgent and emergency care following the temporary closure of the Swift ward. However, recovery plans are established and supported by strengthened clinical leadership, pathway redesign and collaborative working across the local health and care system. Early indicators from these interventions are encouraging, but still need to be monitored carefully and to assess their impact as and how they come through. Financial recovery, as I said, remains our most significant organisational risk, but you do have to say a fully identified £37.9 million cost improvement programme, strengthen governance arrangements, enhance executive oversight and a dedicated transformation capacity provide a credible foundation for recovery. Monthly reporting by the CFO and the Transformation Director will provide the board, I believe, with ongoing assurance regarding delivery of transformation and financial improvement. I believe overall the board can take from the attached reports assurance that while significant challenges remain, the Trust has credible recovery plans, strengthened governance arrangements and targeted improvement programmes in place to support delivery of its quality, operational and workforce financial objectives throughout 2026. However, there is no leeway with regards to programme slippage. And that's my summary.
Thank you, Kevin, and apologies that I made things harder for you by having to sort of make you rush a little bit. But I think everyone has seen the various bits of the IPR in their own committees. Does anyone have any questions or comments for Kevin or any of the other executives on anything in this summary? No, I think your general summary that there's lots of good bits, but clearly the pressure is on both financially and operationally, and therefore I think that those messages are loud and clear to us as an organisation. If we're happy, I'm going to move on. Now, just before we move to the committee reports, I have realised that I let Sylvia go without actually asking the board to confirm the assurance level for the Freedom to Speak Up report, which my apologies. I was in too much of a mad rush to get going. The proposal for Sylvia's paper was reasonable assurance based on what she told us. Are we comfortable with that level of reasonable? Do we want to go up? Yep, I'm getting some nods. Right, thank you. Apologies, I should have said that at the time. Right, in which case, thank you very much. We technically only have 9 minutes left for the rest of the meetings. I may run by an extra 5, but even so, I'm going to ask the committee chairs, please, to literally motor through this. Please take the papers as read. If there is something that we specifically need to highlight, please do so. But I think that the papers are very clear, and I think we're used to the alert, advise, assure format. So hopefully they are fairly self-explanatory. Let me come to them though. Karen, audit and risk. Is there anything you particularly need to highlight to us?
Actually, there is. It's been a busy period for the audit committee with the audit of the accounts. I did want to thank the finance teams and the auditors because it has been a particularly hard year with some innovative accounting arrangements, if I simply summarise it like that, but it's gone extremely well. So it's a thank you to the teams. An unqualified audit opinion was issued on the 26th of June. I do need the board to note a couple of other items. Firstly, that a Sections 30 recommendation will be made to the Secretary of State, but that is in relation to our cumulative deficit, and it is something of which we are all aware. I would also like the board to note the head of internal auditors opinion, which was Amber Green, which reflects where we are in terms of our governance arrangements. In an effort to be quick, I will also then very briefly highlight a couple of issues that have come out of the external auditors' reports. There are 2 reports that we have been through at Audit Committee. One is the Audit Completion Report, which has a number of recommendations which will be picked up through the Audit Committee and will be monitored at the next meeting. But the other report, which is attached to my summary of the Audit Committee report, is the auditor's annual report. And from that, there are 2 items that I think just need to be brought to the board's attention. The first is that the external auditors have identified a significant weakness in our value for money arrangements, which relates to financial sustainability. The area that I wanted to flag is that they are recommending that the work that we do on SIPs in particular becomes much more of a rolling programme, and that we should have this ongoing so that it flows into future years. I know that this is something that is being picked up through FPPC, so I did want to flag that. The other issue that they've raised, which isn't a significant weakness, but is a recommendation that they have put in, relates to our front entrance. And this is a particular project that we are undertaking. They have said that we should look on an ongoing basis at the financial performance of that project. And I think it is important that we do that. And the other is that we look on a rolling basis at the accounting treatment in relation to the front entrance. And this is also something that we will pick up. I would recommend that the board do read the external auditor's report. I would like to say that the absence of other commentary around our governance and value for money arrangements should provide us with assurance that overarchingly our arrangements are reasonable. So that's really all I want to say, and apologies for rushing through it, but all other items, all other actions will be picked up at the audit committee in July.
Great, thank you, Karen. And you were always going to have a bit to say this month for obvious reasons. And thank you for highlighting those things. And we as a board would like to echo your thanks to all the teams involved in getting those accounts done, getting that unqualified audit opinion. The issues they have raised are ones we are well aware of, then that nothing new or shocking. We need to just get on with it. So thank you for that. David, quality and safety. We now have 4 minutes for all the other committees. So I think we are going to be overrunning, and I apologise for that. But are there things you particularly wanted to draw to our attention?
Well, I was going to tell you that my escalation report is going to be considerably longer than usual, and that's because it includes May and June, that we've introduced a new subcommittee, which is the PSSC, and frankly, there are quite a lot of issues on the go at the moment. However, what I've done is remove everything that other people have mentioned, such as the IPR maternity. So that really leaves 3 or 4 things to mention. The first is Martin came to the committee because we had a discussion about quality versus money. Mark came to the committee because we had a discussion about our digital issues. I do want the board to look at the comments I put in my report about orthotics. You know, there's a clinical uncertainty there about the scale of the issue. We should keep a note of that. Complaints are high. They've been a problem off and on for many years. We can't seem to get on top of that. We had another discussion around gynecology services and the reduced patient experience. And we had a good presentation about our pediatric CAM service, but frankly, I still have concerns about the long-term and the capacity issues. I want to end on a high. We've had Prof. Lowe from the Stroke Association join us. It was purely developmental, but the stroke service is doing well at the moment with thrombolysis rate over the last 3 occasions of 20%. That is an international good. So that's fantastic, and it saves lives. Thank you.
Thank you, David, and apologies that you weren't able to give all the detail that you intended. Richard, FPPC, anything you want to draw to our attention?
Yes, Anita, thank you. Well, we heard Kevin talk through the performance and the financial side based on the IPR. The May report that's attached to the papers is not the only meeting we had. We had a June meeting in the meantime, so it's slightly changed on the May situation. But I do want to still pull attention to a few things here. Although we can see progress in some of the operational metrics, in most cases, that progress is behind our own trajectory. So it's going slower than we anticipated. So we really need to up the pace to meet our annual targets. That's really important to note. Cancer, for the first time since a long time, didn't meet the 3 national standards in May. They're still not met at this point in time. We're hoping to be back on track in June, July. So a couple of things that I think we should really take to heart. Financially speaking, it's great that we have now identified the SIP fully to the 38 million. That's our SIP target. But I just want to note that's in the 3rd month of the year. So we now need to start delivering. We had a trajectory which was taking into account the phasing in the first 2 months. In the first 2 months, we're slightly behind financially. but the challenge is going to increase month on month. And then finally, when we look at our activity levels, the activity levels are far below our plan, which doesn't really impact us too much financially at this point in time, but it will certainly do next year if it doesn't change. So I don't want to be glass half empty. We're making progress, but we should really up the pace if we want to meet our annual targets across operations and finance.
Thank you, Richard. I think that sounds like a very fair summary. So thank you for that. Janet, people and culture, anything you need to flag to us?
Well, you'd be glad to know, Anita, because we've had quite a lot of discussion about various elements of people and culture on this agenda. I can keep it very brief. I think the only thing I would like to just highlight is the work that's going to be going on around business partnering, and certainly the discussion we had about that at People and Culture. And as I mentioned earlier on, when Sylvia was speaking, see that as being really quite important in terms of making some of the cultural shifts we need to make, as well as making some of the transformation stick. But other than that, no, I think pretty much everything that's in the report we've already discussed as part of the meeting.
Thank you very much, Janet. Martin, HCP.
Yeah, very quickly, the group continues to meet on a monthly basis. A lot of activity at the moment in terms of ensuring that governance for the HCP is appropriate, on there, also alignment of transformation programs that the HCP is working on with the programs of activity that ICB would like to move forward with. And probably the greatest area of kind of energy and excitement is around neighbourhood health development in terms of bringing partners together and putting bids together in that space. So yeah, quite a vibrant place at the moment.
Thank you. Digital Committee, Richard.
Yes, Anita, I think there's quite a detailed report attached to the paper, so I don't want to repeat everything that's in the report. Clearly, we are concerned about the lack of progress on the One EPR program, which is really down to, let's say, the supplier and their commitments. We are working hard on it. There's a set of measures in place. We need to kind of increase our confidence that they will be able to deliver to the timelines that they give us. Fundamentally, it's not doubting the solution. It is really about the pace of implementation here. And as a result, we had to look at the risk. Currently, a lot of our risks are pointing towards mitigation by those risks through the implementation of One EPR. There's been a good assessment of those individual risks. We have adjusted as a result the annual plan for IT, Mark's area, and are actioning those things. So there is mitigation, there's a response to the delays, but we're still quite concerned that the supplier is going to deliver to the timelines they promise us.
Thank you, Richard. Again, I think most board colleagues will be well aware of that. Finally, Nina, Charity Trust.
So three things. First thing, the Sunshine Terrace is still being monitored. We haven't managed to break ground, as they say, or break air, I guess, on this one. But it is being monitored really closely by Penny. So big thank you to Penny and Kevin for continuing to monitor that. The big build, the fundraising is going incredibly well. The philanthropic board is obviously well established now, and Simon has said that if we do have any big donors between us that we would like him to speak to, then please reach out to him, because he's really happy to do that kind of forward-facing part for the organisation. And then the third thing really was around Thank You Week. So we spent quite a lot of time deciding whether we should go with ice creams for staff this year. And we had a really big discussion around whether that was as inclusive as we would like it to be, because obviously it's a daytime thing. Often weekend staff and evening staff don't get a chance to be part of that specific ice cream gift. And so we decided instead to go for fruit and vegetable vouchers. So actually they will be offered to everybody. People can go and pick it up themselves. So we're hoping that it's a little bit more inclusive, and maybe more a little bit in keeping with the NHS's sort of standards of trying to, eat healthy. You are what you eat. So yeah, that was the highlights.
Great, thank you very much, Nina. Apologies for having run us through those so quickly. I mean, I think sometimes brevity is helpful because it does mean you stick to the key points, but I certainly think there were certain areas where we would have wanted to spend a bit more time. And I actually have a question for us as a board. I do think we have reduced the length of this public board to 2.5 hours. And given the amount of stuff we are discussing, I have a question about whether we think extending it to 3 hours for the public board would be helpful and not make us all feel quite as rushed. Interested in people's views, whether that would be something that we want to do or would rather not. Karen.
I think it would be a really good idea. I think it would allow us to have a 5 or 10 minute break in the middle. I think it's important that we have these discussions in public and important that we feel we can discuss everything in full. So we have been, I think for the last 2 to 3 meetings, we've found it really hard to finish within the 2.5 hours. So I would support extending it to the 3 hours, but with a commitment that people then do need to stick to the amount of time they have for each of their agenda items, and that we allow sufficient time then for the board to ask questions, which is really what we want to be able to do in public.
Absolutely, and I think that's exactly where my head was. Does anybody have any other views, either in support or against? We would keep the private board at the same length, but it would be about increasing this one by 30 minutes, just so that we can get better debate in the public forum. David.
I support the idea. I mean, obviously we mustn't have environmental creep on that. We've got to stick to 3 hours and be disciplined. And I just want to raise the disability flag. I was at an away day yesterday for a charity, and it's really difficult to get people with practical disabilities on boards, and one of the reasons is we don't help them by ploughing through and not having proper breaks.
Completely agree. I would definitely much prefer, again, apologies, I could only give us 5 minutes today, but that's where we were.
It is where we are, yeah.
Exactly. Yes, as I say, I think when I came it was 3 hours, but somehow it appears to have got squeezed, and I'm not keen on it at all, because it's making it extremely difficult for us to get through our business and have the proper discussion that is key to this. Yes, of course, we can look at papers, but it's a discussion that matters. Can I ask then, for some nods, are we comfortable if we extend this to 3 hours going forward from the next meeting onwards? We're getting various nods here. Thank you. Obviously, if we don't need the time, we give it back. That is a hard stop, 3 hours. We certainly won't extend, but hopefully it will give us a little bit more time. Okay, thank you. I wasn't aware of any other business. That was me putting that in at the end. Our next meeting is on the 9th of September. It will be in person at Hertford County. And with that, I'd like to thank everyone, members of the board, anyone watching us on YouTube. Thank you for your attention and your and the good discussion that we've had today. I'll draw this meeting to a close. Thank you. Goodbye.